you start with medical management in all cases. If it's a low risk, you continue medical management. But if it's high risk, impending gangrene or something like that, you have to intervene. Now, see for the lesion, do an CT angio at this point. You see if the block or the level is single block, it's a partial lesion, it's a partial narrowing, and it is a short segment. Okay, then typically these are good candidates for endovascular management. So big vessel, small block, partial block, endovascular management is very good. Long segment, complete lesions, complete block, multiple blocks, then generally bypasses are the treatment. So this is the main dictum which we follow. This is, I think, the rule everywhere in whatever strictures you see, in bowel, in urethra, in everywhere, that if it's a short and partial lesion, we go for endoluminal procedures. If it's a long segment or multiple, then go ahead. Then we cannot do any other thing. The problem comes when it's a small vessel disease, because in small vessel disease, obviously we cannot do endovascular management. And even for locals, because there is a no distal big vessel to anastomose it to. So then it's a problem. That's why in Buerger's, we have to resort to things like lumbar sympathectomies or some other procedures which we'll talk. Now, what does lumbar sympathectomy do? So, for example, this is skin. There are some vessels which come here, and these vessels are also supplying muscles. Because whenever we see that the skin is not getting blood, so what we do is we do a sympathectomy. What sympathectomy does is dilates these vessels. It's a vasodilator for skin, only skin. Remember this. So the blood which is coming from here, it's shunted to the skin, and it is not going into the muscle. So this is what the steal is. Okay, we're stealing the blood of the muscle which comes to the skin. Obviously, if I now ask you in what condition this is contraindicated, okay, you will see when the skin is okay, but the muscle is at the problem. Okay, so in case of claudication, where at this stage at least there is no problem in the skin, and if you do this procedure, what will happen is muscle is already ischemic, the other blood is also diverted to skin, and the patient's claudication will worsen, and that is why that is the contraindication. Okay, so some sympathectomy is done only when you have to improve the vascularity of skin. When it is done under impending gangrenes, ulcers, or a wound which is not healing. If you have done an amputation which you want to heal, the stump should heal, then to protect that, you can do that. If you want to buy some time while you have done an intervention, you can do this procedure. Typically, remember, it will give you some time only, because what happens is the sympathetic fibers try to grow over from the other side and again cause vasoconstriction of the skin. So the failure happens, but it gives a very good window of preserving the skin vascularity, which works very magic. Whenever you do these cases and in the evening you touch the feet of the patient and you compare with other limb, you'll see the difference. This limb is warm and nice. So it is important. So this is what it is. And in cases of acute limb ischemia, there's some special scenarios we'll discuss, which generally presents with 6 Ps. They present with pain, pallor, pulselessness, paresthesias, paralysis, and poikilotherma, or it's cold basically. So to remember these 6 Ps. Remember, this is an acute setting. Typically, I have seen students telling this 6 Ps in chronic ischemias. Chronic ischemias does not present like this. Okay, the whole symptom is very different. This is only in acute limb ischemia. Okay, this is acute embolic event, or if the thrombus has bled inside, or it has suddenly come and block the vessels, then only you will have this kind of symptom. In these cases, apart from the other things like doing a Doppler, getting the block done, endovascular management, all that thing, IV heparin has a role. So immediately you have to start IV heparin, because mostly, again, I said it's thrombus. So we have to break that thrombus. And then we have to do a catheter directed thrombolysis. So what we do is we'll go right at the site of embolus or thrombus, and then we try to dissolve it by giving thrombolytic agents right at the site. Okay, so this is what we do. So embolectomies, bypass surgeries, if this does not work, or sometimes we dread that, but amputations also is an option or is required in some settings.